Hello, welcome to Ask Alumni, the podcast where we talk to alumni of Loma Linda University School of Medicine to gain insights and information to help students and young alumni on their medical journey. Hello, I'm your host, Calvin Chuang, and today we're going to be talking to the wonderful Dr. David Wood, Loma Linda class of 1980, about orthopedic surgery. Dr. Wood, thank you for joining us and welcome to the podcast.
Thank you so much for interviewing me.
So you're an orthopedic surgeon. It is one of the more commonly known specialties, but for those who know nothing about orthopedic surgery, can you describe your specialty for us?
Sure. We take care of the surgical and non-surgical treatment of the musculoskeletal system. So typically you think of a rotator cuff tear, a meniscus tear, arthroscopy of the shoulder, the knees, carpal tunnel, and then we do a lot of back surgery as well. We also do a lot of the trauma. We fix fractures of the femur, arms, bones from motor vehicle accidents, sports injuries. So it's basically the musculoskeletal system that we take care of.
Okay. And how did you personally decide on being an orthopedic surgeon?
That is the question. And with the medical students, that's the one everybody's going to ask you. First, they ask you, what are you going to do when you're in college? Then you finally decide you're a doctor going to be in medicine. And once you're in medicine, then they say, what kind of medicine? So the questions never stop. Then once you decide that, they're going to say, when are you getting married and when are you having children? So it's always another question. But I came from a background. I had an uncle who was a physician, and I had a father who was a carpenter. And as we know, Jesus was a great carpenter. I've always liked working with my hands. As I was going through residency, I was enthralled by OBGYN, delivering a baby. There's nothing like that new life and the joy of the family and delivering a baby. But I wanted to deal with both women and men, and then both young and old. I also looked at urology, but that's primarily a lot of men. And so I thought with orthopedic surgery, I can do young and old and men and women, and it truly is. And the other nice thing about orthopedic surgery is that action activity. You know, people come in, a kid comes in with a broken arm and he's not very happy, and you set that arm, you put it in a cast for 6 weeks. The mother's happy, the family's happy, the baby's happy, and it's a great feeling.
Oh, great. So there's actually a lot of gratitude, I guess, that you experience firsthand from your patients then.
It is. I looked at some of the other residencies, and if you've interviewed an internist or a cardiologist, and they have a lot of chronic disease, and we have chronic disease, chronic low back pain, chronic knee pain brought on by patient misuse of their bodies, people who are overweight, tremendously overweight, and their knees are worn out. And so there are some things that we can't do, but for the most part, we're able to alleviate the symptoms, unlike some of the other fields of medicine that just, for instance, diabetes, you give them insulin, but they always have diabetes.
Hmm. So that sounds like one of the benefits of your specialty. What are some of the other aspects of orthopedic surgery that you really enjoy?
I think the thing about orthopedic surgery is that you're typically seeing, we don't do well body checks. People don't come into us just, I want to go see my orthopedic surgeon. They come to us because, I fell down, I broke my leg, I broke my arm, I tore my meniscus. I have this pain in my shoulder. I have this and the different aches and pains. And for a lot of the times, there are things that we can make a direct impact on and drastically change how they're doing. If you come in and, Calvin, I know you like to play tennis. If you come in and you went down for a squat for a backhand, and you felt your knee pop and you had a twist and you had an effusion and swelling in your knee, well, you have an anterior cruciate ligament tear and a meniscus tear. And we're able to take that knee and take you from a guy who can't play tennis anymore to being able to return to his tennis field game. And I think that's the most satisfying part of it. Now, the other aspect of orthopedic surgery is that as you get older, and certainly you can see from the class of 80 that I'm an older fellow, that we're able to go into different aspects of it. And right now, I do a lot of what is the workers' compensation practice. And so these are patients that get hurt at work, and then there's a dispute about how bad they're hurt. And so they have an attorney and the insurance company has an attorney. And one doctor says the patient's so badly injured, they'll never work again. And the other doctor says, there's nothing wrong with them. So they send them to me, and I evaluate them, do an MRI, do diagnostic studies. And as in so much of life, typically the answer is somewhere in between, that they can go back to work, but not the heavy work that they were doing before. And so that's a mentally stimulating part of the practice that I enjoy at this time.
Right. Now, you mentioned that there were other aspects. Do people who get an orthopedic surgery, do they specialize in certain areas, or is it something that you kind of do a bit of everything?
Sure. And I think for the young people coming up choosing residency, for the most part, it seems specialization is almost required nowadays, unless you go to a small town. So in orthopedics, we have quite a few different specializations. The main one would be hand. And so if you go into hand, then you're doing the rheumatoid arthritis and you're doing hand replacements, or if you have a laceration of your hand through the tendons here, you'll go see a hand surgeon, or if you cut a fine nerve. So we have hand surgery. The other one that is big is sports medicine. And that's what most orthopedics practice for rotator cuff tears, tennis elbow injuries, meniscus tears, knee injuries, those sort of things. Then you have total joint specialists. And total joints typically do the hip replacements and the knee replacements. So if you're going into that, you're typically dealing with the older population, usually 50 and older. You're required to do hospital care because most of those are done in the hospital. And then there's follow-up. But you drastically change a person's life who cannot walk because of a bad hip. Then they have a surgery, and then 3 days later, they're walking out of the hospital. So that's a great field. Other fields are pediatrics. There's a lot of congenital deformities here with pediatrics of the hand and foot and spine. We have spine, which is a complex field in and of itself, and we share that with the neurosurgeons. Both of us do spine. And each of those are a 1 to 2 year fellowship after you do your 5 years of residency.
Okay, so there's room to move within the specialty as well, sounds like.
Yes.
Now, you've mentioned some of the strengths and what you enjoy. How about challenges? What are some of the challenges of being an orthopedic surgeon?
Well, the challenges we have are brought on by a couple things. And for the new residents coming out, or new students coming out, orthopedic surgeon demands a lot of your time. One of the benefits of the new medical field is that with managed care and the large groups, that you're able to have your time controlled. For instance, at Kaiser, you work a shift and then you go home. In private practice, you go in for your time and you go home when the patients are done. You're responsible for weekend care. You're responsible for other things. So one of the big complaints about orthopedic surgery is that it's very busy. And it can be, unless you get into a practice where you can get to control the situation. One of the new programs that they're doing now for orthopedic surgeons is you'll be the orthopedic hospitalist. So you work there at the hospital, you come in the morning at 8 a.m. and you go home at 8 p.m. and you take care of everything that walks through that door. But when you go home, you're going home. And then there's another physician, someone you know, who comes in and does the 8 p.m. to 8 a.m. shift. So they take care of the hip fractures that roll in. And then they go home and they're able to sleep. So you are able to control your practice setting. I think probably one of the more frustrating parts of orthopedic surgery are patients who come in with complaints that have unrealistic expectations of what they can achieve. And if their expectations exceed my goals, and a frequent one for that will be someone who comes in and their back is just rotten from top to bottom. All the discs are bad. They're 350 pounds. They are smoking, which is another problem with arthritis. And they want us to just take care of them and fix them. And so a lot of orthopedic surgeon we can take care of directly, but a lot of it is managed by the patient. So it's having realistic expectations of what we're going to be able to do for you. I see people who have bad knees, for instance, and they're only 30 years old. as you know, total joints are put in older people and 50 or above, and they want us to fix them. And sometimes we can't fix them until they get to that point where you can replace the knees. And I look at it like your tires. If you only have 20,000 miles on the tire and you need a new tire, we probably need to do something else.
Mm. And have you found any kind of tricks or things that you found work well when dealing with more difficult patients?
So, Calvin, when I was at Loma Linda, I had a couple of physicians show me how to examine patients. And the key, I think, to being a good physician is to have empathy for your patients. They want to see you come in. They want to have you listen to them. They want to have you sit down. They want to have you lay a hand on them and examine them. And then they want to come up with a plan. My personal practice routine has me always sitting down on the stool with the patient. I always make a point of making sure I touch them. And you can't believe how many patients come to me and they've seen 3 other doctors, and I have them get in a gown, and they say, why? I say, well, I need to examine you. They say the other doctors just sit across the room and ask me to stand up and bend over. So do a thorough examination of the patient. And then the last thing I do before I leave the room is I always ask them, do you have any questions? We've all, and maybe not all of you as your young medical students, maybe you haven't been a patient, but having been a patient myself, you want to have an answer to what's going on, or you want to have some suggestions. And my practice, I always try to share my medical knowledge with the patient. I know some doctors are offended if the patient comes in and they've looked up WebMD or they've Googled the entity, but I'll tell you, I'm thrilled with that, because I think the more the patient knows about the medical condition, the better it is. If you're explaining a bad back to a patient and you have to go through the whole anatomy of the disc and the facet joints and their vertebral bodies, it takes much more time and is much less efficient than if they've already looked into that. If you're describing their meniscus tear and they've already gone to YouTube and see how a knee surgery is carried out, they're going to ask much better questions and will leave the room much happier with how their treatment is going to be carried out. So I encourage internet knowledge of their medical condition.
That's interesting you say that, because a lot of times people reference that as being a problem. But it's nice to hear that someone actually says that it's actually something that works well. You've mentioned this personal touch and personal care. What other traits, though, make a good orthopedic surgeon? So that's can be answered in 2 questions. For an orthopedic surgeon, you want to have a caring physician, and you want to have a skilled technician. And they may not be the same doctor, frankly. If you have a non-operative condition, you want to have somebody who has a good bedside manner, has a good program to take care of your needs and try and get you feeling better without surgery. If you need to have surgery, and I personally have had surgery on my knees, and I wanted to go to a great technician, because remember, we're getting in there and we're sawing. If you're getting your knees replaced, we're sawing off the end of the bone. We're doing cabinetry on your knee. And so you want to have a guy who's a great technician, and you're not as concerned about his bedside manner. If it's an operative condition, that's who you want to go to. If it's a non-operative condition, you want to have the best bedside manner that you can go. And for the medical students going through, when you're having to get your own health care, always ask the anesthesiologist, because the anesthesiologist is always in the OR. They see who's the good surgeon when things are going well. They see who's the good surgeon when things are going bad. They see who not to go to. And I've always found if I'm looking for a reference, to talk to the anesthesiologist in the hospital, and they'll hit it right on the nose as to who to see. That's a good tip. That's something that I'll remember if I never need surgery in the future. Tell me about, you've been doing this for a while now. How has the field changed, or has it changed over the years?
When I first started out orthopedics, everyone went into private practice, and there was not the subspecialization. So I started out at San Bernardino County Medical Center, which is the old Arrowhead, and that was over in San Bernardino, clearly. And I was there with Jim Matico and Ken Mudge, both Dr. Matico's alumni of Loma Linda. And we ran the county practice. So the three of us took care of everything that came in, and that was spine fractures, open pelvis fractures. If you were the guys who like to hang glide off of Crestline, which is the center of hang gliding for the United States, would come in with these big open tibia fractures, and we would take care of everything there. Now, things are specialized a lot more. I don't do total joints. I just do primarily arthroscopy. We have a separate spine surgeon who does the complex spines. So everything has been much more specialized, and the groups tend to be larger. We now have 32 physicians in our practice, but things tend to move forward and get larger instead of smaller.
Okay. And when you're working, are you working mostly, has it become more individualized or team orientated, or how does that work now these days?
Well, it's just you're doing the same thing, you're just doing it within a bigger group. So I was at Arrowhead Orthopedics, and I worked there for until the late 90s. And then I went into my own private practice, and I started workers' compensation practice. And so if a patient's at work and they hurt their back lifting something, or they cut the tip of their finger off, or they have to fall under California workers' compensation laws. And you have to fill out different forms, and you have to go through different hoops to do it. And it's a bit of a pain in the neck, but once you have your practice set up, totally do it, it does pretty well. So I moved over into the workers' compensation system, and I hit it pretty hard. We had a large group. I had 15 doctors working with us. We had a physical therapy department. We opened up our own operating room with our surgery center. We had our own pharmacy. We had 150 employees. So it was a moving and shaking group. And I think I enjoyed probably the business end of the medicine and growing that group as much as some of the surgery that I would do. So that's another option as a physician, that you go into management. Nowadays, everybody's expecting to have an MBA, but you can go into management besides just doing your medical practice. And a lot of you guys are smart and business savvy and may want to pursue that aspect of medicine.
That's a good avenue, I guess, for those who like to hustle. We might touch on that a little bit later. For now, with orthopedic surgery, what does a typical day look like for you?
So for a day for me is clinic 2 days a week, surgery 1 day a week, because I'm semi-retired. But let's talk about a general orthopedic surgeon before I slow down. So typically you have clinic 3 days a week and surgery 2 days a week. So you go in the clinic and you start at 8 o'clock, and you have nurses, and it's just like any other clinic that all you students have gone to. The key, and I can't emphasize this enough, is to get a great nurse that helps you with your clinic, because they can make or break you. And we go in and we have the new patients, and they room the patients, and they ask them questions, so that when you come in and you pick up the chart at the door, and let's see, that's my FedEx envelope. Well, you pick up the chart, and you know that this patient being seen for a hip fracture, or this patient being seen for a torn meniscus, or this patient being seen for a rotator cuff. So then you spend the morning seeing patients. Then with those patients, a lot of them are post-operative follow-ups that you've seen from your surgeries. They're new patients with new injuries that you're seeing to set up for surgery. And then there are non-operative patients. And those are people who have a tendonitis or have a trigger finger of their hand that you might do a cortisone injection on, that don't need to have surgery. And so you do the clinic, and then you take a lunch break, and then you go back in the afternoon and do another clinic. So you'll see 30 to 40 patients in that day. And then then you'll go home, and you may be on call that night. So if you're on call that night, the emergency room calls and you may have to stop by, and there could be a hip fracture or a wrist fracture, and you'll have to go to the emergency room, and then you may have to go to the operating room that night. Hopefully what you can do is set it up for the next day so that when you're in your hospital or in your operating time zone, you could do that hip fracture. So the next day you go to surgery, and surgery is really so much fun. For those of you who are of the surgical bent, you go in there, it's the same crew, you're working with the same people. After doing it for 4 or 5 years, you've got it all down and there's no big surprises. It's just an enjoyable time to be in the OR. You're making patients better. You're taking care of pathology that these patients will really do well. So you might do between 4 and 8 cases, depending on whether they're small hand cases or bigger cases. And then you go home that night, and that you won't be on call because you're on call Monday night. And then the next day is clinic again, and it's repeated again. And then the Thursday would be surgery. And then the Friday, hopefully you get off someday, but the Friday may be another day of clinic.
Sounds very busy and like a very active kind of specialty then.
Most orthopedic surgeons are moving, rock and rolling most of the time.
So you get your steps in for sure then. Now, knowing what you know now, with all the experience that you've had, is there something that you would have liked to have known early in your career about orthopedic surgery?
Yes, I would have liked to have known that I should have bought Apple with every dollar that I had. The interesting thing about medicine, and for all the medical fields, I'm sure it's the same, the progression in medicine is gradual. It's rare that you walk in and suddenly, boom, all of a sudden we've got some tremendously life-changing practice that we're doing. I've been able to experience a lot of changes in my 30 years, and it's been interesting to watch it go. For instance, when I was just starting orthopedics, before that, we didn't really have arthroscopy. And so arthroscopy started about 6 or 8 years before I started orthopedics. So before that, if you had a meniscus tear, they would cut open your knee and just take out the whole meniscus. Then we started doing the arthroscopy with the cameras, and you guys have all seen arthroscopy or endoscopy, and it just was totally changing. But it's not something that happened. We didn't go from non-arthroscopy to totally arthroscopy. It took a gradual time. We got better with the surgeries. Initially, we just would go in and take out a loose body. Then we got better instruments, and we were able to do the meniscus resections. Now we're able to do meniscus repairs. We're able to do our anterior cruciate ligament reconstructions just through small incisions. So I think that's probably the neatest thing is seeing the gradual progression of things over time. In trauma, it's made great advances. When originally, if you broke a bone, you would be put in traction for a very long time. Then we came up with the femoral nails and the plates that allow us to put fixation in and get immediate fixation of your bones so that you can get up and get moving and thus not get pneumonia or the pressure sores or all the problems that come with those. So that's been a great progress as well. But I think I don't think I would have liked to have known anything more. I think it's been a gradual transition and gradual improvement with medicine that we're all comfortable with. And it's the same way in cardiology or any of the other fields that makes gradual progression in their medicine.
So more evolution rather than revolution of techniques.
It's a more evolution than that's a great phrase. I'm going to keep that, Calvin. I won't give you credit though.
That's fine. Is there a specific evolution that you're excited about that you're seeing orthopedics going into that you're like, I'm so excited that this direction?
I think one thing that we're emphasizing now more is hip arthroscopy. The hip has always been kind of a difficult joint to get into because it's deep inside. You can do elbow arthroscopy, it's right here. You can do wrist arthroscopy, it's right here. I won't show you my knees, but it's right there, as you know, and the shoulder's right here. But the hip is deep inside. So we have special instruments now, and I think that's probably one of the fields that I think is moving most rapidly forward at this time is hip arthroscopy. The total joint field, there's changes and there's differences, and one of the best things is in the old days when a patient would come in, they'd come in the night before to the hospital. So if you're having surgery on Wednesday, you'd come in Tuesday night to the hospital, you'd get prepped. You'd be in the hospital for 3 or 4 days afterwards, sometimes a week. Now, you come in and replacements are done as outpatient surgery. So you come in that morning, you have that surgery, and you go home that same day. So that's one of the more revolutionary things that we have, the move towards outpatient surgery. I know people are doing non-anesthesia hand surgery. So you go to the doctor's office, and instead of having to be NPO the night before and getting an IV started and doing all this stuff, you go in and he just puts a tourniquet on your arm and blocks it and is with a nerve and is able to do the surgery right there. And you essentially can drive yourself home. You don't even need to have somebody take you. So we're moving towards a more rapid access and rapid treatment for some of these problems.
That's amazing. We're talking to Dr. David Wood. He's describing the wonderful world of orthopedic surgery. More from him right after this break.
This episode is brought to you by the Paying It Forward Scholarship of the Alumni Association, School of Medicine of Loma Linda University. Every year, junior and senior medical students at Loma Linda University are eligible to receive a scholarship equivalent to half of 1 year's tuition. Students who receive this scholarship also receive advice and encouragement from the alumni who helped fund their scholarship. For more information, visit LLUSMAA.org/paying-it-forward-scholarship or call 909-558-4633. Support also comes from the Student Ambassador Program of the Alumni Association, School of Medicine of Loma Linda University. Did you know medical students can receive honorariums starting at $500 for encouraging Loma Linda medical alumni to become members of the Alumni Association? Simply have alumni credit you in their perpetual membership upgrade. Help us build our community today. For more information, visit LLUSMAA.org/student-ambassador or call 909-558-4633.
Welcome back. We're talking with Dr. David Wood, Loma Linda class of 1980, about orthopedic surgery. Now, Dr. Wood, you described for us some of the things about orthopedic surgery. Let's talk about, you touched on the business side of things. Let's talk about business and creating an orthopedic practice. What is that like?
Well, you're going to know whether that's something you want to do or not. A lot of people are very happy to go in and go to work and come home, I think that the key to having a happy life is knowing who you are and doing what you like to do. And as medical students, you're soon going to be hiring and firing people. And when you're hiring and firing people, get people that are the right personality for that job. If you need a marketer, don't get a person who's great with numbers and is a CPA type thing. But on the contrast, you don't want to have a person who's a great social, interactive marketing person that's going to be running your books. You want a person who can't stand it that they can't find those last 10 cents. And they spend an hour trying to find that 10 cents. That's who you want running your books. So choose the right person for that field. And for me, I've always enjoyed medicine, and I enjoy fixing a fracture or doing a knee scope, but I also enjoy the business of medicine. And it's fun to see the thing grow. It's fun to take it from one doctor to 10 doctors and to take it from one clinic to 5 clinics, and getting the mechanisms in place to take care of those patients and those doctors. But it has to be something you enjoy. If you don't enjoy the business of medicine and would be just happy to have somebody else look over it, then take that role. But here's a word of warning here. Probably half of the orthopedic surgeons I know have had some sort of scam. And typically it's that office manager who they just could not live without. And she was the greatest office manager they'd ever had. And she worked all the time and never took a vacation, and just they could count on for everything. Well, the reason they never took a vacation is because they were skimming the books. and putting money in the backside. And they were afraid if they took a vacation, you would look at the books and find them. So you want to have a healthy respect for the practice, the business practice, and have checks and balances in place, because probably half of the people I know in their practices at some point have had problems with money disappearing out the back door, would be a nice way of saying it. So keep your eye open for that, even if you don't want to run the business yourself.
That's some really good advice.
That's a solemn note to be bringing to medical students.
Yeah. It's always good that's like street smart skills that they probably didn't teach you in medical school. Now, when you were building up this practice, is this something that you had to teach yourself on the fly? Did you learn by observation of your current practice when you're just being a clinician? How did you get into this world of owning and starting your own practice?
Sure. I can't emphasize enough. I think, whether you call it a mentor or a big brother or a friend or a partner, if you're going to be exploring other options and going into, you just can't get enough information about that. And I had the great fortune of when I started my surgery center, I talked to a couple of doctors who had just done it within 2 years. And so they had all these tips and all this knowledge, and they put me in touch with the right people and the right contractors and the right architects and the right attorneys. So never be afraid to reach out. People love to talk, and look at me, I love to give advice. If you go to them with an open hat, unless you're going to be setting it up in their backyard and to be direct competition, they are more than happy to share their experience with them and give you the do's and don'ts of how to run the practice. So that was probably the biggest thing I think I did that helped me out. I was able to reach out to other people. There's management practice and there's MBAs and those sort of things. And I have to say, I just didn't access those and wasn't available to me. I was able to get, fortunately, a manager who I kept my eye on, and we did not get scammed, who ran a great practice for us. And it's reaching out to people, expanding your skill set, and choose other people that you trust and have great confidence in, and delegate the responsibilities for those. And let's look at Elon Musk. I mean, what a great guy, Elon Musk. But he didn't build that spaceship. He didn't build the car. He didn't build the solar system, but he's got that idea. And he keeps an eye on the things, and he would look at it, and he had that vision as what to do, but then he brought in the right people for it. And he held everybody's feet to the fire. I remember reading that when he was looking at the sun visor on the Tesla, and he just couldn't stand it. He said, every time I look at that sun visor, there'll be a nail shooting into my eyes. Now, that's probably a little more dramatic than you need to be, but he is a great example of somebody who has a vision and then brings in the right people to help him manage that vision. So I can't emphasize that enough. Surround yourself with good people and listen to them, trust them, and use their skills.
That's some really solid advice there. Now, do most people who become orthopedic surgeons, do they generally build their own business, or do they, for the most part, practice and just have that as their job?
I think when I started practice 20 years ago, it was totally different. Everybody primarily went into private practice. Now everybody is pretty much going into group practice. And so you're going into group practice where there might be 150 physicians. And a perfect example is the faculty medical office there at Loma Linda. You could, if you're an orthopedic surgeon, you go in there and you work and you do your thing. And then you find out that you want to do some management. So you get on a committee or you get on a board, and then you finally can work your way up with those things. But mostly now everyone goes into groups, large groups, smaller groups, so they are able to maintain a lifestyle that they're comfortable with and also maintain a practice that they're comfortable with.
So it sounds like there's some pros and cons there with lifestyle and practice for, from going into a group versus doing it yourself.
Yes.
What are the pros and cons? What are some other pros and cons of each?
Well, so it's what is the pro is typically the con for the other.
Right.
So the great thing about being in practice is that you're the boss. And if you're a control person and your wife, when you go home at night, and your wife says, why don't you just do it? Because it's got to be your way or no way. Then you should be in your own practice, because until you do that, you're going to always be complaining, always be fussing. If, on the other hand, you come home and she's done it one way and you say, well, that looks like a good idea too, and you can live with that, then the group practice may be more beneficial. When you're in a group practice, you need a successful group practice capitalizes on the benefits of being a group practice. And that means that they use, for instance, one medical record system, then everybody having their own. They use one, they try to get one system for a casting material. For instance, in orthopedics, we're all going to use the same casting material. We're all going to try and use the same implants. When you're in a large group, if I'm out in private practice and I get a hand that comes in, I'm the only one that is there, I try to do it, and I might not do the best job. If you're in a group practice, you can pass that over to one of your partners who just does that. So that's one of the benefits of a group practice is a volume of scale. You have one administrator that manages 20 or 30 doctors versus paying one administrator to manage 2 or 3 doctors. But that's also the problem, because now you have to conform with the other doctors. And for the most part, people sit down. It's a democratic system. You talk with your partners, you come up with a plan as to what you want to do, and you use that. If you chafe under that ruling, and you may change, you may go in and start it out, and then you may work at a Kaiser, a multi-specialty clinic, or a large group, and then you just say, I can't stand it. They make me do this, and I don't want to do that. What I want to do it my way, and I want to do it this way because my way is the best way, and I'm the only one who knows it. Well, then at that point, you're probably going to need to get into your own practice and run your own practice. And then once you see the joys and the sadness of running your own practice, you'll be a much wiser physician as you go back into a group practice.
So knowing yourself is probably a good thing when you're deciding, making that decision then.
I think that's it. Knowing yourself and knowing, like Clint Eastwood said, a man's got to know his limitations.
Right. Now, when
medical students probably don't know who Clint Eastwood is.
No, I'm sure they do know who Clint Eastwood is. He made some movies that I'm pretty sure that they've watched. When you're talking about, some of these students are going to be considering compensation as far as their residency choices and their specialty choices. When it comes to orthopedic surgery, what's the pay like, both in a group setting as well as private practice?
Well, Calvin, now you're getting into a little embarrassing part. What I'd like to say is that orthopedic surgeon is typically the number 2 or 3 in compensations when you look at when the pay scales come out. Okay. So we are well paid. We have high malpractice rates. We work very hard. We have 5 or 6 or 7 year residency and fellowship. But we are compensated well for that. So if you're interested in getting if you're interested in being remunerated for what you do, orthopedic surgery typically is one of the better fields for that.
Mm. So that's good for them to know, but it sounds like it is a long road to get there. It's not like the rewards come in instantly.
It is. It takes a while, but it's a joyful field. I once again, for the most part, patients come in and, I was in clinic this morning and I saw a couple of patients I'd operated on, and they're doing great. The knee feels great. They did the surgery. They're moving it. They're walking around. They're very happy. They're ready to get back to work. And it's a very satisfying field for the most part. Every day, if you think you're not going to have every day some setbacks, and you're going to have 1 or 2 patients who are just unhappy and not doing well, you have to accept that's part of medical practice. But you want to be in a practice where people, and that's why I like orthopedics, you fix them and they're doing better.
Now, you mentioned that, things don't always go right. How is, lawsuits in America are quite common. How does that play into your specialty in your field, and how do you deal with that?
Well, unfortunately, lawsuits are common. People have unrealistic expectations about how their treatment's going to go. And I think the way to control that is to have realistic discussions with the patient and realistic expectations from the patient. I can't tell you how many patients I've seen who've transferred over to me for one reason or the other and they say, well, I said, how are you doing? They said, not very good. Or the doctor, he said, I was going to do great. I'd be 100%. And if a doctor ever tells you you'll be 100% after surgery, I suggest you get up and walk out of the room. In fact, run out of the room, because no one can guarantee that you'll be 100%. I'd say probably 90% of the time when I talk about surgery with a patient, they always ask, as they should, well, how am I going to turn out? And you can never say how that one patient is going to turn out. What you can say is, if we do 100 patients, and this is where you have to keep up on this stuff. If we do 100 knee scopes, there's going to be 2 or 3 that get infected, and that's just a matter of business. I mean, I remember there was a famous football player, and he had his knee scoped, and here he's making multiple $1 million, and he got infected. So it can happen to anybody. We've all heard of that child who goes in for a tonsillectomy and doesn't make it out, or somebody had a minor procedure and throws a blood clot. So patients always want to ask that, and I say, I can't tell how you're going to do. What I can tell you, if we have 100 patients, that 80% of them will be happier than they were before. And then I go through the numbers depending on what the procedure is. And you guys will, I'm sure, gone through lists of do's and don'ts when you're explaining consents, and we all do the same thing: bleeding, infection, death, and then the specifics for that injury. Because I always tell the patients, there's no small surgeries, only small surgeons. And the other quote is, it's better to have a great anesthesiologist and a poor surgeon than a poor anesthesiologist and a great surgeon. Because you can live with a poor surgeon, but a poor anesthesiologist, you might not live.
Talk about that partnership for a moment. Is it good to have a good partnership with your anesthesiologists and those who work with you? Do you work with common teams? How does that look like?
Calvin, I would not say it's good to work with an anesthesiologist and have that. I don't think that's appropriate at all. I think it's essential to have a great relationship with the anesthesiologist. The reason it's so essential is that, for instance, we have our own surgery center. So we come in there in the morning. And the reason we have surgery centers is that in the hospital, and you all have rotated through the Arrowhead Regional and private hospitals, Loma Linda, and you come in at 7:30, I'm ready to do my case, and there's a gunshot wound that just rolled in, or there's a aortic aneurysm, or there's a laceration, there's something. There goes my day. So I had this day blocked out perfectly, and now somebody else has jumped in front of me. So we have our own surgery center, and that's like the operating room of a hospital in an outpatient setting. And it's essential to have a good working relationship with them so that they're comfortable, that you don't want to take unreasonable risks, but that you want to get through the day. And they're will appropriately manage their patient's risk factors to be able to do your surgeries. Now, there's some times where you might have a patient come in there and they just say, Doc, he's got PVCs and he's got hypertension, and I just don't feel comfortable doing this. I think we're going to have a cardiac event if we put him under anesthesia. So it's important for you to talk to the anesthesiologist, but more importantly, you have to listen to them. And one other thing here we're going to talk about, that is wrong site surgery. We've all seen that happen one way or the other, unfortunately, and we all have to go in and sign the leg we're going to operate on and put it in the notes, but still wrong site surgery happens. So pay close attention to that. When the nurse does the timeout, don't be on your iPhone, or don't be thinking about where you're going to go for dinner. Be focused on that case. Make sure the right procedure is done for the right patient every time.
And that's some very sound, solid advice, I think. I hear a lot, and we've been doing a couple of these interviews right now, and that relationship with your fellow coworkers has something that's come up quite a bit. Do you have any fun stories or interesting stories that you'd like to share about, like, why you enjoy orthopedic surgery? That's a good example of it.
It's the day-to-day thing. Frankly, well, here, I'll tell you. So I had a gal, she was in a motor vehicle accident. She came into the hospital, and she was a quadriplegic. And she was like 22 years old and couldn't walk, couldn't use her arm, was a quadriplegic. Anyhow, I operated on her neck and took out a bony fragment and stabilized her neck. And then, I saw her. This was when I was at the county practice, so we didn't really have a personal relationship with them. I would stop by and see her on rounds, but we didn't follow her up afterwards in my clinic. She was in the county clinic. And anyhow, then about 18 years later, I was in my office, and her husband shows up in my office for another issue, and she was there with me. And so here I to see a woman 18 years later that was a quadriplegic when you first saw her, and now has gone on to lead a totally normal life and has had children and has had a great life, was just a great thing. That's the thing that brings a tear to your eye when it's so happy. That's probably the more dramatic event. It's always fun, and I encourage people to stay in teaching institutions. It's always fun to work with residents and with the medical students, and I enjoy that. Teaching the nurses, I like to let the physician assistant help out at surgery. So it's more of the daily things in these huge dramatic things. I'm always surprised about the good in people, and I'm always surprised about the bad in people. But I think if you keep an open heart and open mind to good people, your practice will grow and you'll do well.
Mm-hmm. Now, as you look back at your career, and as you look back at all the lessons and wisdom that you've gained, is there any last minute advice that you'd like to give these students and those listening?
Well, these are weighty subjects here, Calvin. I think probably one of the key things is to enjoy every day that you go out. And I can think particularly of one friend of mine. And when we were in medical school, it was always tomorrow, mañana. When we were underclassmen, I can't wait until we get upperclassmen. And he was single. Then we'll really get the chicks. Then when you were in upperclassmen, I can't wait till I'm an intern. Then that'll be really cool. I can't wait till I'm a resident. I can't wait till I'm a fellow. I can't wait till I'm in practice. And the guy is still unhappy now, still waiting for something. So, and that's probably a personality that you'll never change. But if you can enjoy every day, it's never better than the day you are. I mean, people who think, I can't wait for 5 years until I can do this, or I can't wait till this. Each day is just a great gift to you. You need to enjoy it. And that's not to say you're not going to come home. Like last night, I finished up the office at 7:30. I had 2 just tremendously difficult cases that I had to do a lot of research on, and came home and oh man, live. This was a tough day. But if there's no tough days, there's only good days, you won't enjoy the good days. So I think you want to enjoy every day as much as you can. Know that, live that day. And I won't be so gross to say carpe diem, but you have to just enjoy your life as you're going along, because there's always another day after it, but it never gets better than where you are right now, usually.
So that gratitude then is essential, it sounds like.
I think so.
Yeah, and I think that's a great place to, speaking of gratitude, to end today. Dr. Wood, we are grateful that you took the time out to talk to us today. Thank you for all this information. I'm sure it'll be very, very helpful for students.
All right. And Calvin, I want to thank you for that evolution, not revolution. I'm going to keep that in my book of sayings.
No worries. And that concludes our episode for today. Ask Alumni is a podcast of the Alumni Association, School of Medicine of Loma Linda University. If you'd like to hear more podcasts like this, visit our website at lousmaa.org/podcasts. And if you have any questions or would like to see a specialty featured on this podcast, email us at lousmaa@lou.edu. For now, I'm Calvin Chuang. Have a blessed day.